I get to introduce Bianca Haas. She's one of our lead representatives with our UGI NDX community. Take it away, Bianca.
Thank you, Jessica. Good morning, everyone. Thank you for joining us. I know we're eager to get started. I'm the Business Development Manager for University and Institution, if you don't know me. And I'm going to let Kelly Bevington take it away into the circle of digital dentistry. Thank you so much.
Good morning, everybody. Good to have you here. I'm sure I've met most of you, if not all of you. We're going to talk about the evolution of digital dentistry, and I'm excited to share the information with you. I did also just put in the chat my cell phone and email, so if you have any questions, comments that you'd like to address, I am here and available for that as well. So let's get right to it. Some disclosures. I'm a full-time employee of NDX. I do not receive additional compensation from any vendor partners or so forth. This is our intraoral scanner training team. So one of the things that NDX has available to you as a resource and a support are 3 individuals across the country that can assist you specifically with intraoral scanning, connecting with the lab, different types of STL file management, things along that line. We focus primarily on restorative scanning, best practices for acquisition, as well as things that are still newer to people, primarily scanning the edentulous patient for prostheses, whether it be a fixed prosthesis or removable, and scanning for implants. We've got some helpful documents to provide to you. And let's talk a little bit about why people have chose to go digital here over, it's hard to put a timeline on things sometimes. I realized not long ago, it was 18 years ago that I did my first certification with a scanner, with an intraoral scanner. So even though we think that digital is new sometimes, it's been around and it just continues to evolve. In the last 2 to 3 years, just skyrocketed. So it really helps to improve that patient experience. It engages the patient when you as the clinician are equipped with the information and skill set to share the scan with the patient and explain their oral health condition. It really improves that patient experience. Plus, they don't have the wet, goopy material in their mouth for a traditional impression. Accuracy, we find as a laboratory that accuracy is superb with intraoral scans versus analog. And what I mean by that is we measure things by returns, right? By remakes. So with analog, we hover, 4.5 to 5%. Remakes with traditional impressions, whereas with digital, we're more around 2.5. So we find that as a win. It does reduce your chair time. You gain chair time because you're able to see more patients. And ultimately, when you're very efficient with it, it reduces your overhead expenditures because you're not using as much impression material, if any, for some practices. Now, I'm a dental lab, right? So, and I'm also an RDA EFTA by original training. I worked clinically for about 12 years before joining the lab. So I'm never going to suggest to, throw away all of your PVS and alginate materials because there is a time and place for those materials as well. Please know that the first time you take a scan, you are typically not an expert. It's a very, very small percentage of doctors that I have worked with that have been able to just pick up a scanner and go to it and capture all of the necessary data. It really depends upon your learning. There is a learning curve is really what I'm trying to get at. Although I must say with the younger crowd, you all sort of pick up on it quicker than I did. That's for sure. So we, as a laboratory group at National Dentex, receive approximately 3,500 scans every day, and this list continues to grow. The items mentioned on the left-hand side, iTero, Trios, Medit, PrimeScan, Dexis, that's what we receive the most of, and we are very well trained and equipped to manage any incoming scanner file. They are all STL files or PLY files for the most part, and we're able to work with any of them. I thought this was an interesting stat that 58% of clients who have an intraoral scanner system, it has increased by 53% since 2022. So we really saw a surge in adoption after COVID, after 2020. What can you take a digital scan for? Really, just about anything today. So when I first started with intraoral scanning, it was full arch scans of dentition for bruxism appliances or aligner therapy. And then, I take that back. The very first time I was training, it was specifically for a single tooth crown prep. Then it migrated to full arch of dentition as well, and now it's everything. I mean, scanning for an implant, a custom abutment, and a crown, one of the easiest procedures for removable partials and dentures, working very, very well. Surgical guides, of course, but anything with a full complement of teeth is very, very easy to scan. And the way technology is evolving, the acquisition of gingival tissue is getting better and better and better every day. So when looking at digital scanning in general, it's not only why do you want to go digital, are you technology driven in your practice? Talking about file needs, and always want to experience a demonstration of a device for sure. So we're going to talk about a couple different types of scanners, right? We've got Align, we've got 3Shape Trios, we've got PrimeScan, Medit, lots of different options there, right? So the diagram here is showing sort of the difference yet similarities with traditional analog workflow versus a digital workflow. There's still always a receipt of the information, right? Whether it be a PVS impression or a scanned a file, right? There's always some sort of a model generated, whether we are pouring a model, which really doesn't happen too much these days, or if we are creating a virtual model. So even PVS impressions that come into the laboratory, we scan those impressions and then we can print a model if a model is required for that type of prostheses. And then it goes down the line, right? I mean, some of the processing is a little different, but typically a milled crown, a full contour zirconia crown, that part of the process is going to be the same. And then we're still looking at our final stain and glaze, final QC, as well as shipping out. So differences on the front end, similarities in the middle and on the tail end. Every file, every impression is evaluated and margin marked. And we're talking about crowns here, right? And part of the positive of this is it really allows us, and it allows you on the scanner end of things, to see your margin close up and personal. So if there's ever a question about the quality of a scan per se, you can see for sure when you blow it up on the screen, and you should blow it up on the screen to make sure that, you know, the margin goes 360 degrees, that there's not a step, that it's still clear and crisp, and that it is exposed, right? So intraoral scanning is not ultrasound technology, right? It's not ultrasound technology. These cameras, not yet, hopefully in my lifetime, they cannot look through blood, saliva, and tissue. So it's up to the clinician to expose that margin so that it's visible to the camera itself. When working with PVS materials, oftentimes they are hydrophilic, and they the compression of the material disperses the material away from the tooth, right? You express it into the sulcus, and that exposes the margin. So when you're doing a digital impression, it's equally important to expose those margins. So this is an example of the iOS portal, that incoming file that we talked about, right? Lots of data. This is the image that you would see on your screen in monochrome. When we do the design at the lab, it is done in a stone model or monochrome mode. That's why we suggest to people to always look at your scan in monochrome, not just color. So as dental professionals, we all know the difference between enamel, dentin, and gingival tissue. It's like clear as day to us. However, it's the lab working in the monochrome for the design software. They have access to the color and they can toggle back and forth, but it's really important that you are able to successfully see your margin in monochrome. Example of that there. And then the final. So although we're very familiar with file management and so forth, it does provide us an opportunity to reduce fabrication time in most cases. You can see how we're starting here with monochrome for the design aspect. This is a 3D milling, or a milling center and 3D printing, both. So we talk about CAD CAM. So CAM is computer aided manufacturing, and the CAD is computer aided design. At the end of the day, we're still treating whether it comes in as a digital impression or an analog impression, we're still treating that crown really pretty much the same towards the end, right? You're still doing characterization with staining and glazing. It's still going through a final QC. And so let's get into the impression taking itself a little bit. So proper isolation is going to be really, really important. As I mentioned, it's not ultrasound technology. Complete acquisition of the data is really important. So no missing data or holes that we refer to in an area that is critical to the fabrication of that prosthesis. So what do I mean by that? If it is an impression for a single unit crown, you want to make 100% certain that the mesial and distal contact walls are free of any holes or missing data. You want to make sure that that's filled in. AI exists, right? And if the scan itself has too much of the holes filled in with AI, it's a bit of a disservice to the fabrication of the crown in the first place, because it will not be perfect, right? It's guesstimating with AI. So do your very best to acquire all of the crown prep, all of the opposing, and all of those interproximal contact walls to ensure accuracy. Again, you want to expose that margin, make sure that you can see it 360 degrees. Typically, a crown prep for digital scanning, we have the greatest success with a shoulder or chamfer margin prep, right? It just makes it easy for the camera to see it. What you do want to avoid, though, is a very sharp line angle if it's a shoulder, right? So the inside of, the top hat, as I would call it. Think about it that the burr, right, when we are milling a crown, that the burr cannot get into a sharp line angle. So you want to make sure that you keep it rounded and smooth. For either a shoulder, a chamfer typically doesn't have that. What I do recommend people try to avoid is a bevel prep. All right. So a bevel is more that shoulder or chamfer, and then a little tail to it that goes the whole way around. It goes 360. What I see is if that bevel is not clearly identified to the lab, like make a note in the RX that it is a bevel preparation. Oftentimes the lab doesn't see it. Right? They just don't see the tail of the bevel unless it's very, very clearly identified, that final finish line. So what happens is you end up receiving a crown that you perceive as short, right? Or a very large open margin. And the reality is the lab misread your prep. So it's all about collaboration. It's about communication. So the more information you can provide to the lab, the better outcome we will both have for your patient. And then the dentists that I work with, that I ask them what type of a preparation is their go-to, and they tell me, oh, I like to do a knife edge or a feather edge just tucked subgingivally. I'm like, oh, that's hard. It's really hard for the camera to see that finish line unless you are really, really committed to using like a dual cord retraction cord technique, something that you can retract that tissue away from that feather edge. And it's hard if it's sub G, right? So we all do the best with what we have. Again, if it's a feather or knife edge margin, please make note of that in your communication to the laboratory on your RX. So here's a couple items that I have found very helpful to use in real life dentistry to help with isolation and gingival tissue retraction. So out of everything on the page, for sure, my favorite is the NeoDries. Every major manufacturer has some sort of a dry angle like NeoDry. So it's much better than a traditional cotton dry angle. Cotton dry angles can work well. Most cotton dry angles I see in practice are the ones with the mirrored backing. And the mirrored backing is great when you're prepping because it gives you more light. It gives you more illumination. But illumination and light when you are scanning is a bad thing. You always want to make sure that if you wear loops, that your lights on your loops are turned off, that the overhead chair light is turned off, any extra ancillary light, streaming sunlight in through a window. If you have blinds, close them. All of that extra light causes the camera to not stitch together the images quite as well because of that reflection. So no mirrored dry angles, use a regular cotton one or something like NeoDry, and you're putting it on the inside of the cheek against the parotid gland. And why that's helpful is when you're scanning, you're pretty consistently retracting the cheek. And for some people, not all, for some people, you're milking that parotid gland, and it all of a sudden you just end up with all the saliva on the mandibular arch. You're like, where's it all coming from? These other items can be helpful, especially when you're new to scanning. So ScanMate is an autoclavable retraction device. So you could also use a plastic mirror or a tongue depressor. And then the lip and cheek retractors work really nicely if you're scanning for a full complement of teeth. And every scanner is a little bit different, right? So some of them have a very small head to it, a camera head. The small camera heads, I really like the lip and cheek retractors. The other ones have larger camera heads. iTero and PrimeScan, for instance, have a little larger camera head. I use the camera head, the lens of the wand, not the lens, but the tip of the wand to actually retract the lips, cheek, and tongue itself, right? I'm not using an extra device. So it sort of depends upon what type of a scanner you're using as well. This is a great one. So confirming that you have adequate preparation and reduction of your occlusal surfaces. So if the lab is reaching out to you periodically, asking for additional reduction, asking if they can reduce the opposing or provide you with a reduction coping, something like this might be helpful. As new clinicians, eyeballing your reduction probably isn't quite adequate yet. If you've been doing this for 30 years, and we've got some faculty here, that's a different story. We have a different level of experience, right? But something that you can physically confirm that you have adequate reduction, whether you're using a bite tab like this. So Prep Check allows you to put the light green end in the patient's mouth. They're going to tap, 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 very similar to articulation paper. It's going to leave markings on that occlusal surface, and you know where to go back in and reduce just a little bit, right? You see the markings. And these come in a multitude of sizes. You know, usually it's 1.5 millimeter is what we're looking for. There is a cost associated to it. I think they're like 75 cents each, but that adds up, right? So you could use a ball burnisher. You could very inexpensively use a piece of wax and then measure it with calipers to make sure that you have that 1.5 millimeter of reduction. But it's important that you have that. And also know that all of the scanner, most all, I never want to say all because about the time I do, something's come up that I'm unaware of. Most all scanners today have a software program built, has a platform built into the software program at the very end of the procedure that allows you to confirm if you have adequate reduction or not. And so it's sort of like a traffic signal. Red is bad, yellow is okay, and green is good, go. So the problem with that is if you only find out about it at the end of the procedure, you're going to have to re-prep, erase and rescan, and then retake the bite registration. So in my opinion, in my eyes, I think it's best to check this before you ever take a digital or a physical impression for that matter. This is an example of a nice, clear, clean, exposed margin. Could have used a little smoothing here of that bicuspid, but I wanted you to see what good retraction looks like in general. And what is my go-to? So my go-to for gingival tissue retraction is a dual cord technique. So 2 cords. I will use a 00 first, cut to the exact circumference of the prep, tucking it completely in. Then that second cord might be another 00. It might be a 1, it might be a 2, depending upon the health and condition of that gingival tissue, but something to retract it laterally, right? So the first cord is providing apical retraction. The second cord is creating lateral retraction. A Fisher's cord packer is my favorite, and that my hemostatic agent of choice is going to be Viscostat. Lots of different manufacturers out there. This is just what has worked well in my hands if you've never used cord and you're looking for a suggestion. Now, is there other ways of achieving gingival tissue retraction? Yes, absolutely. So retraction paste is probably one of the most popular out there. There's lots of different types of retraction paste or comb fords or foam cords, or Voco has a new one out. It almost, when it sets, it almost peels out like wax. It's pretty cool. Excuse me. What I find is if you're applying the paste yourself, you want to make sure that you're expressing it into the sulcus itself. And if you are delegating it to an assistant, you want to make sure that you're educating them on what the retraction paste is supposed to do. Oftentimes, I find that the retraction paste is just sort of laying on top of the tissue. It works great as a hemostatic agent, but it didn't do anything to push that sulcus out of the way and expose the margin. So I also like to use it in combination with a compress cap, a little cotton compress cap. Works really, really nicely when the patient is biting into that compress cap. It's sort of like if we have a wound on our hand and we're applying pressure, them biting into the compress cap is helping to stop the bleeding as well. What I don't like about retraction paste, and this is in my hands, right, is oftentimes I find that I have to rinse it so vigorously that I actually cause some hemorrhaging to occur. And that's incredibly frustrating once you've got everything really nice and dry and ready to go. People will ask if these other techniques can work. So laser can work really well. I don't know, since I've never used laser, obviously not being a dentist, I don't know if it's the setting on the laser, if it's the tip they've used, if it's how heavy-handed the clinician is, or the patient's tissue, right? But sometimes it's really nice and smooth and it works great. And other times it's more like electrosurge, right? And there's just these heaping mountains of burnt tissue that makes it really challenging to get the light of the camera over top. It's almost like it looks like mountains when you're trying to scan over it. So be careful with that. Be conscious of that. Rotary curettage is what I understand this technique to be, is when somebody takes a burr and goes around the prep, removing the tissue. The thought process is that when they come back for the seat of the crown, that the tissue will be in great shape and very nice and healthy. And that probably is true. But to get a good scan of that bloody sulcus tissue, being sort of in the way, and trying to maintain hemostasis after the burr has been used is really challenging. So be aware of that as well. Just some examples of good, bad, and ugly scans. So this is really nice and clear, right? And this is a monochrome, of course. Another good view. Again, you always want to look at it in color as well as monochrome. Here's another great example. Now this one, it looks pretty clear here in the color, but then when you look at it in the monochrome, you can see an area on the distal buccal where the tissue is sort of in the way of the margin itself. Missing data. These are real life cases, right? So it was deemed acceptable to submit this case, and the whole contact wall is missing, as well as the adjacent teeth, right? So years ago, when scanners first came out, oftentimes I would hear usually salespeople selling the scanner make a comment, oh, it's digital. All you need to do is capture one tooth distal of the prep and one tooth mesial of the prep, and it's good to go. And what we have found as a laboratory is that's not the case, right? The more information you can provide, the better. In today's scanning is so fast today that there's really no reason not to do a full arch. a single tooth and it's a quadrant and the patient's bite is nice and solid and you were able to acquire a good, accurate bite, I think a quadrant is fine. But anything more than 2 units for sure, do yourself and your patient a favor and do that full arch scan. Again, some more missing data. And these are holes, right? So you can see the holes on like the incisal edges. This is a good one where the lip was captured, like the inside of the lip was captured, and it actually caused sort of corruption to occur on the prep itself. Again, real life case, right? This was for a partial, not enough data, right? Not enough data. And that's really what I'm trying to get at, is distortion and data is critically important, right? And you're able to see this on the screen yourself. A margin that we cannot read, right? So let's talk a little bit about how we've incorporated into implant scanning. Lots of different types of implants, lots of different types of implant scan bodies as well. And so know and understand that what the laboratory needs from you is what the implant manufacturer is, so what the implant is in the bone, what type of scan body it is, the platform size, what custom abutment material you want, what crown material you want, and if the crown is going to be cement or screw retained. Those are all necessary items. It's also critically important that once you place the scan body, that you take a radiograph confirming that it is fully seated. It's really important to not skip that step. You want to take that x-ray to verify, because that's the beginning of everything, right? That's the foundation of this case. And I have been chairside where we thought for sure the scan body was fully seated, only to take an x-ray and it was not. So we've sort of learned through this evolution of digital dentistry that that's a really important component not to skip. And when you're placing scan bodies, every scan body is going to have a key identifier, a little slant, a divot, a dimple, whatever that key identifier is. Try to face that buccally. It will have the acquisition of the image much faster. It's easier for you to access that way. I do recommend full arch scans for implant cases, and know ahead of time that you will typically not be able to take a bite registration with the scan body in place. So most all of the scanners out there, when you go to the implant scanning page, or X page, if you will have different drop-down menus for you to select your implant type. So what type of implant is in the bone, and then what type of scan body you have. If they match, right? If you want a OEM, original equipment manufacturing workflow, you want that scan body and the implant in the bone to not only be compatible, but be of the same company. That's going to be important. And then there's typically an option for you to do a pre-treatment scan. A pre-treatment scan allows you to remove the healing abutment or healing cap, take an image, take a picture of that tissue quickly before it collapses. And that's critically important if this case is in the aesthetic zone. If the patient has been in a provisional where the tissue has been very carefully sculpted so that the papillas are perfect for no black triangle effect, you want to make sure that you provide to the lab that tissue scan so that they can, when they're designing the crown, they can provide a beautiful emergence profile for you. We talked about different types. We're going to quickly finish up with removables, right? And some of the evolution that has occurred with removable prostheses specific to iOS workflows. So in generality, there is something called a reference denture, a copy denture, and an immediate denture. A reference and a copy denture are typically a 3-appointment visit where your initial scan is your master impression. It is your final impression versus analog, where that first impression is typically an alginate and it's always a preliminary impression. So with digital, it's your final impression is your first scan. Then the second appointment is going to be a functional try-in. And then your third appointment will be the insertion. And that's if everything, goes according to plan. The thing with digital denture workflows is every patient is a little bit different. Every scenario is a little bit different. The really nice thing is there's so many different variables to the workflow that we can make anything work depending upon your needs and the patient's needs. So it might not seem straightforward at first, but we can get it there. And sometimes in doing so, I'll use the word digitally assisted. We might do something that's a little bit analog. So as for instance, typically I get a question right now about, well, wait a minute. What if my patient walks in, they're fully edentulous and they don't have any existing denture? That's okay. We can still move forward. So you can do the maxillary scan to the best of your abilities, right? Your mandibular scan to the best of your abilities. You could provide some sort of a mush putty bite or mush, wax bite, and perhaps score the midline and a high smile lip line, lip at rest line and canine guidance just to provide that as preliminary information to the lab. Now, depending upon how accurate, how good your initial intraoral scans were, meaning did you capture all of the necessary anatomical landmarks? Were you able to capture the buccal vestibular muscles? The lab might be able to go to a try-in. And it could be a digital printed functional try-in. Or if you want it to be wax and you want to be able to physically manipulate, and customize those anterior teeth just so, you can do a wax try-in as well. Or the lab might say, oh, wait a minute, those scans weren't so great. What I'd like to do is to provide you base plate and bite blocks, allowing you to take a wash impression inside of those base plates. And a wash impression we'll get to here in just a moment, but it is expressing a heavy body material around the borders, placing it in the patient's mouth, doing muscle toning, phonetics, capturing that buccal vestibular muscles, right? Then taking a wash impression, a light body wash inside of it. So you would do the impression part first, then put both the maxillary and mandibular base plates with bite blocks into the patient's mouth, adjust a wax accordingly to verify vertical, then do your scoring of the midline, lip lines, cuspids. And at that point, you could either scan these 360 degrees, right? Or you could put it in a box and send it to the lab. The lab has a desktop scanner that they will scan it 360 degrees and move on to the try-in, whether you want that to be a printed functional try-in or if you want that to be a wax try-in, completely your choice. Otherwise, the copy denture is that patient that walks in, they love their denture, and they want an exact copy of it. They're going to be cruising this winter and they just want a backup. You can scan just the denture itself and the lab can copy it. You can make slight modifications with occlusion, not a lot, but slight modifications with the occlusion. The reference denture is the patient that comes in, they have existing dentures, but they're far beyond a repair or a reline. Maybe they've cracked in half, they've been super glued back together, but we're gonna use that as the best custom tray ever. And what that looks like is doing that that border molding again, right? That light body wash again, and submitting that, then scanning it and submitting the scan to the laboratory. What I love about that particular workflow is the patient is never without their teeth. So otherwise today we would use that existing denture as some sort of a, mock for the lab and take the impression inside of that denture and send it to the lab. This way, when you're scanning it, you're able to peel the impression material out and give the patient back their denture. And then lastly is immediate. Immediate is like easy peasy with scanning. Just make sure you get your, your hamular notch, your retromolar pad, your vibrating line, the buccal vestibular muscles, and you will be good to go. This is pretty much what I just said. Here's some images for the reference denture technique, right? You want to make sure it's all nice and cleaned out first. This is the border molding. You're applying some tray adhesive to the intaglio of the denture before applying the impression material. That's it as a complete. Here's some more examples of what that looks like on the intaglio and what that, some images of scans themselves. A little bit about design. This is the functional try-in. The functional try-in is a monochrome material. It is printed, and it's all one shade unless it's a very specific aesthetically concerned patient. We can apply pink sort of from cuspid to cuspid for that view. And at this stage, you can still make adjustments. You can take a burr to it. You can see that we took a Sharpie marker to it to communicate to the lab that the midline needed shifted a little bit. We wanted a little rotation of a lateral, or you want to bring out the buccal corridors. So communication can still happen at that point. And so that is basically that, 3-appointment denture that we talked about. An immediate, of course, as an immediate is going to be 2. And here are some immediate scans, right? These were not acceptable because the buccal frenum is not present, right? Those buccal vestibules were not well captured. And that is going to wrap it up. I know I spoke a little bit fast, maybe a little bit too fast. I was concerned we would get behind, but what type of questions, comments, concerns might people have? Please know that we have a plethora of information when it comes to intraoral scanning in general and digital dentistry for that matter. Some references from today's information. And we thank you for joining us today.